Okay, Randall, you're ready to rock and roll.
Okay, well, I'm glad to be here again. Like I said, did one of these talks a couple months ago. Again, for the last 13 years, to those of you that may not be too familiar with me, the last 13 years, my practice site has been Dr. Sarah Juden's clinic. Great site. I get students there most months, 2 per month. So it's a wonderful training site for the students. It's an honor to really work with Dr. Sarah Juden and help with the patients at Heart Solutions. And so with that, I'm going to go ahead and go over one of my favorite topics, which is the anticoagulation, and I'll focus on the clotting cascade. I have several abbreviations that I will look at tonight, and those are here for your reference. So I always like to start off, whether I'm talking to whatever audience it be, medical students, pharmacy students, whatever. I always like to set the background up before I get into the drugs, because without a good background, the drugs aren't going to make a whole lot of sense. So, going back here to basics, a foreign blood clot consists of 2 components. You have fibrin, which obviously is the end product of the clotting cascade, and of course you have platelets, okay? And I like to think of it as sort of they seal the deal at the end to make a blood clot. They shake hands. You have a couple of receptors that are key on the surface of the platelet to facilitate this interaction. You have glycoprotein 2b3a and PTY12. So at a later talk, I will focus more on the platelet and discuss more of the drugs that focus on that portion. Okay, so with that being said, obviously drugs can work on parts of the clotting cascade, which I'll put that up here in a minute, and they'll work mainly on inhibiting platelets. Tonight's talk, I'm obviously going to focus more on the clotting cascade. At a later talk, I will focus more selectively on agents that inhibit the platelet. Okay, so I realize this is a busy slide. I know I tell pharmacy students they see the clotting cascade probably 1,000 times in pharmacy school, and they get to my rotation, they see it for 1,001. So I'm sure all of you all are familiar with the clotting cascade. So obviously I'm just going to point out some basic stuff here. Obviously fibrin is here at the end of this thing to stabilize the blood clot, but you have an intrinsic and extrinsic pathway. So you have factor 12 getting things started here. On the intrinsic side, the A, by the way, stands for activated, okay? So the way I think of the clotting cascade is kind of like you set up a whole bunch of dominoes and you knock one over and they all fall over. That's sort of the way it works, is that something triggers the clotting cascade, usually some sort of endothelial injury, a cut, an MI. Something triggers it. You have the intrinsic and extrinsic. The extrinsic starts as factor 7, and it dominoes down to factor 10A, which of course begins the common pathway, and obviously several drugs target this factor, and of course you domino down into fibrin. So what's another take-home point I want to point out here for you all is in this cascade there are lots of targets here that drugs can take advantage of. And so we have to list the clotting cascade in order to understand the drugs. Okay, so this slide here is several years old, but I'm going to use it again. This is the platelet. So again, tonight's talk is really not the focus on the platelet, but just here it's showing you the platelet shaking hands with the fibrin. You have the glycoprotein 2b3a receptor. You have ADP, which sort of basically turns on the PTY12 receptor. Okay, we'll have those drugs. You have thromboxane, which is involved in the activity of aspirin. So the platelet has several targets for drugs as well. And again, you bind to fibrin. All right. So as I explained, to a lot of students, kind of like the government, you have a set of checks and balances. There's a reason why we don't just make blood clots all day. Okay. So we have certain things that naturally inhibit the activity of the clotting cascade. Some of y'all may be familiar with them. Okay. Protein C and protein S. I know, back when I used to do warfarin clinics years ago, we get people in here that are quite young that have blood clots. Well, that's not normal. So I'm going to have what you call protein C deficiency. Antithrombin 3, plasminogen, heparin, TPA. Our endothelium lines, by the way, all the arteries and veins in your body. Just familiarize yourself with that. These make these natural anticoagulants. So these sort of helps keep the cascade in check and make sure that we don't just make blood clots all the time. All right, so you have numerous sites, obviously, that are targeted in this cascade, okay? Some work more directly on clotting factors directly. So warfarin, rivaroxaban, apixaban, dabigatran, these bind to factors selectively. Then you have some that work more indirectly, okay? For example, increase the activity of natural anticoagulant, like our heparin compounds, okay? Pentasaccharides, thrombolytics. I'm going to go through all those classes here this evening. All right, so I put this slide up here. I found this over the internet. Really, this sort of puts things in historical perspective. I always like to go back into history and look at pharmacy. So way back when, about 100 years ago, somebody discovered heparin. Okay, so it's showing you that here. All right, we begin to use heparin. Okay, very old drug. Okay, then they found basically an anticoagulant in sweet clover. And then somebody around the 50s or so discovered something that is called hydroxycoumarin, which is the derivative of coumadin. And they got that developed, and then of course, obviously in the late 50s and 60s, warfarin became more mainstream. They figured out how warfarin worked. Okay? And of course, obviously, somebody much smarter than me back in the 80s and 90s figured out that, hey, let's have something more clean than heparin. They came up with low molecular heparin compounds like Lovenox. And then, of course, we had a drug and we'll talk about here shortly called fondaparinux. And then around 2010, we started a new age. We started basically the newer anticoagulants. So that's what I'm going to focus a lot of my attention on tonight, is the newer stuff made from 2010 forward. So this slide really puts it in perspective. So we used coumadin for a long time as our first line drug. Okay, so the first drug I'm going to talk about, old unfractionated heparin. Okay, so it potentiates the activity of antithrombin 3 to disable certain clotting factors. So if you remember a few slides ago, antithrombin 3 is one of those natural anticoagulants, so it's potentiating its activity. Because it's such an older drug, you have all kinds of uses for it. I'm not going to read them all, but obviously you can treat DVTs and PEs. They use it in the cath lab. There's lots of different uses for old heparin. It is a weight-based dosing, so because of its short half-life, being a pharmacist, I have to look at pharmacokinetics. Many times when you give this drug, it's going to be given as a continuous infusion, which makes it sort of a pain, okay? Any drug I'm going to point out here tonight can cause bleeding. You get thrombocytopenia. The thrombocytopenia can be quite problematic. I don't know if anybody's ever heard of HIT syndrome, heparin-induced thrombocytopenia, okay, HIT. That sort of was the main key driving point into how we got low molecular weight heparin products available, all right? Other known effects of this drug, osteoporosis, hyperkalemia. Again, heparin's not a clean drug. You give this drug by sub-Q or IV, you never give it IM. Why is that? Because there's a very bad risk of a hematoma, okay? So we don't ever give a lot of these anticoagulants that are given in the injectable site IM. So as I mentioned, a newer, cleaner compound was developed several years ago, low molecular heparin. So it works the same way. You know, you're basically potentiating antithrombin 3, but it's a little more selective for the factor that begins the common pathway, which is factor 10A. Okay, remember that diagram earlier with the clotting cascade? You get factor 10A as the common pathway. Okay, pretty much the same uses as you see now for unfractionated heparin. So this drug is mainstream. We use it all the time in the ER. You know, we use it to treat blood clots during pregnancy. So a lot of the same indications as you saw for old heparin. Okay. Right now we have two main products available, Fragment and of course Lovenox, but I'll tell you in the real world 99.9% of the time it will be Lovenox that you see. That's sort of king of the hill basically. So it's the most widely used agent. It's generic and it has lots of data to support its use. Pharmacists must know doses, so I'm going to make sure that I mention the key doses with you all. I tell my students that, you know, if you know anything about low molecular heparin, know your doses of Lovenox. If you're treating something, treating an MI, treating a DVT, treating a PE, 1 mg per kilo Q12. Prophylaxing somebody in the hospital, obviously with DVT risk factors, 40 milligrams sub-Q once daily. So I mentioned this, I'm gonna highlight this. The kinetics of these class of drugs, the kinetics of Lovenox are much more predictable than unfractionated heparin. Why? Because I think of heparin as a big, giant, clumsy molecule. It's unpredictable, it's erratic. Okay, this drug is much smaller. However, a side effect of that is it's renally eliminated. So old heparin doesn't really get filtered by the renal system. This drug will. Half-life is 6 to 7 hours. Hence, because of that, that's why we can give this drug via IV. So I made this slide pretty much on my own just to really simplify things. So basically you have unfractionated heparin here, and about 80% of that molecule is just junk. And because it's a junky molecule, it's erratic. So somebody basically took out the active moiety of that, okay, low molecular heparin, and then came up with Lovenox. So that's simplistically how this is working. I mentioned that because the drug is small, it does get filtered by the kidneys. You must really dose this. Okay, so 1 mg per kilo Q day for treatment, 30 milligrams once a day for prophylaxis. You do get bleeding and thrombocytopenia, but here's the key. Much less incidence of HIT syndrome compared to old heparin. Again, you never give this drug IM, okay? All right, this drug's been around forever. And when I did this discussion several years ago, I spent a lot more time on warfarin. But I'm not going to do that now because we've got some not much newer drugs that are better. So this drug's been around forever. It inhibits vitamin K-dependent clotting factors. Okay, it historically has been the drug for chronic treatment for anticoagulation up until around 2010. So this was a drug you gave to treat DVTs, PE. This is a drug we gave for AFib. Okay, you still get this drug quite a bit for mechanical heart valves, but this was the drug for the longest time. Now guidelines have come out in the last few years. For example, the latest atrial fibrillation guidelines basically now said that the drug is inferior to your new anticoagulants. They were first called NOACs, novel oral anticoagulants, but because they've been around now for a while, now we refer to them as DOACs, direct oral anticoagulants, so direct acting. So the dosing of Coumadin, I don't have time to really go through that, but you must start people out mostly at 5 to 10 milligrams. You know, there are so many strengths on the market. Because this drug has erratic pharmacokinetics, pretty much everybody in this room might require a slightly different dose of Coumadin. So the drug's just erratic. You know, you can get bleeding, something weird called purple toe syndrome can happen. I've only seen a couple of cases of that in my career. I mentioned that this drug works on inhibiting clotting factors, which basically depend on vitamin K conversion. Okay, well, it's no secret then that the antidote to this drug is vitamin K. You've probably heard this too. People are taking Coumadin. Vitamin K is loaded in green leafy vegetables. So here's the thing I used to get from patients. They say, well, I can't eat vegetables because I'm on Coumadin. Not true. The key thing is consistency. I've dosed Coumadin to 30, 40 milligrams a day in people that are vegetarians. I just say, look, you can eat however much veggies you eat, just make sure it's consistent. Otherwise, the INR is like a roller coaster. Drug interactions. I could also spend all night long on drug interactions with Coumadin. Okay, whenever you see Coumadin, you got to look up drug interactions. To make it simple, I always refer to this as the Fab Five. Okay, there's 5 drugs: amiodarone, fluoroquinolone antibiotics, metronidazole, which is their antibiotic, azole antifungals, particularly the old ones like ketoconazole, sulfa drugs. These inhibit the enzyme 2C9. Again, I don't want to make this pharmacy talk, but 2C9. We call it the Fab 5. So whenever you see one of these Fab 5 drugs, the INR will go up. You got to be very careful with that. We monitor Coumadin, as you probably know, by the INR test. Stands for International Normalized Ratio. We used to use the prothrombin, but the INR is now standard for that. You probably know this. For most treatment indications, the goal INR is 2 to 3, except when you're dealing with higher risk patients, the old mechanical heart valve patients, 2.5 to 3.5.
Is there any new data that looks at patients staying within therapeutic range, the percentages of patients that stay?
There's several. It's basically out there in the literature where they look at like pharmacist-run clinics and show that they can get people in range maybe up to 60-70% of the time. But the key thing is, it doesn't matter if you're a PharmD, a nurse. You will get a higher chance of having people in range the more intensely you monitor. Okay. And obviously, in very busy physician practices, sometimes that's not possible. I know for a while with Dr. Sarah Judy, back before we hired a PA and so forth years ago, I would help follow up people on Coumadin. So you can get up to, say, around 50-60% or so therapeutic range. But even then, you sit there and say, what about the other 40%? It's pretty scary.
You get the right number actually. The going number outside is 60 to 70%, even during research. When they do the research studies,
Sure.
So on average, the coded rate is 60 to 70%. That's exactly what. So basically, what they're saying is the best case scenario.
Right.
You're gonna have 60 to 70% who are in the goal range. If that answers you,
Yeah,
but you're exactly right on the head. So.
Well, I'm glad to hear that because it's been a while since I've looked that up. I'm like, I thought I remember that figure 60 to 70% is some of the pharmacists.
Because we talk to a lot of coag clinics and just different conversations, and a lot of times that number's coming out of the coag clinics is a little bit higher, or perceived to be a little bit higher, that they're within range. But
well,
I get it. Yeah.
That's human tendency.
Sure.
Yeah, but the bottom line is Coumadin's a pain. Even though some of the DOACs have come along, it sort of means a little bit less business for pharmacists running coag clinics. I know if I was a patient, I wouldn't want to take Coumadin as a first-line drug. So that's the key thing here. Okay, so moving on here, the next class of drugs I'm going to talk about are pentasaccharide compounds. Okay, these are even smaller than 1 molecular heparin. So they took that molecule, made it even smaller. Okay, and it selectively targets TNA. So you know what I'm setting up, don't you? like we had somebody talk about Xarelto earlier tonight. This drug formed the basis for some of the oral 10A drugs we have now. We started out about 20 years ago with fondaparinux. Okay, so this drug, we can use it for DVT prophylaxis and treatment of both DVT and PE. Okay, where you might also see it used is if you have to use an anticoagulant acutely in somebody that has developed hip syndrome from heparin. You can't use low molecular heparin, you can't use heparin. You could use fondaparinux. That is one use that they still could use it. All right, the only one in this class is Arixtra. So this slide's several years old. This is showing you here, anthramin 3, which obviously your heparin compounds help augment. You potentiate that activity, and pretty much what you do is you inhibit the cascade at the common pathway starting with factor 10A. So obviously here you interfere with fibrin clot conversion. That's pretty much the mechanism of fondaparinux. Okay, you have your dosing there. The drug is given subcutaneously, by the way. 2.5 once a day for prophylaxis, 7.5 for treatment. You have a pretty good half-life there. But even this drug too can cause bleeding and thrombocytopenia. So here's the role in therapy. We don't use it much. I've been out of the hospital for several years, but I don't know any of y'all in the hospital. I don't know if you've ever come across fondaparinux, but to my knowledge, some of the older studies looked at it head-to-head against enoxaparin. And it's one of those things that while enoxaparin was established, it was sort of king of the hill. You have to show me how this other drug is going to be better than the drug we've got now that's a standard. Well, basically, fondaparinux really didn't do it. So that's why I don't think you see it used as much now. Okay, next drug class of drugs, thrombolytic agents. These are going to be more acute care ER type drugs. So these take plasminogen, which is an actual anticoagulant converted to plasmid, and I call these the clot busters because these literally go to fibrin and blow it up. That's exactly how they work. They're quick acting, they're IV. Boom, they blow up fibrin, okay? So where do we see them used? Well, if you asked me 20 years ago, I'd say, oh, use it a lot for STEMI, ST segment elevation MI. Now in 2019, the main use for them is going to be for stroke. I'm going to explain why here in a second. Okay, so we use them for STEMI, we use them for severe pulmonary embolism. You probably say, why don't we use thrombolytics for in-STEMI? Because with a non-ST segment elevation MI, you have a more platelet-rich thrombus, okay? With a STEMI, you have a more fibrin-rich thrombus. So if you look on a package insert for, say, Alteplase, it'll say something like, contraindicated without the presence of ST elevation. Because you don't have enough fibrin substrate in a non-STEMI for this drug to work on, therefore you're giving a drug that can cause bleeding. So it's only indicated for a STEMI or severe pulmonary embolism, okay? I mentioned right now that the main use for it is for ischemic stroke. The old cutoff was 3 hours. The guideline now says you use it within 4 hours and 30 minutes of onset of symptoms if you're treating an ischemic stroke. You can also use it for IV catheter occlusion. So anymore, I think the main one you're going to see is going to be TPA. So you have Alteplase there. TNKs is still around. We used to have some others like streptokinase, Redivase. Those aren't around anymore. Again, these work very rapidly. These can cause severe bleeding, so you can have a whole laundry list of contraindications. Your dosing is going to be different, obviously, for your indication. So you can't use the same dose of Alteplase for an MI as you can with a stroke. Back on MI for a second, I forgot to mention. I tell students that if you're going to see, say, a lytic given for an MI, it's typically going to be somewhere where they don't have a cath lab really available, or you're out in the sticks, so to speak. You're way out in the panhandle. You're way in southeast Oklahoma, where you're more than 2 or 3 hours transport time away from a cath lab. We've known now for several years that the best treatment, obviously, for outcomes is get somebody with an MI in the cath lab and get PCI done as quick as possible. We know now that beats giving a lytic, but like I said, if you're more than 2 or 3 hours out, you still might see a lytic given. Okay, well, I forgot to mention that for all of you. Okay, so obviously look at your package insert because there's lots of contraindications. And some of them listed there. Okay, moving on. NOACs, that's the real crux of my talk tonight. Okay, these are also called NOACs. Newer guidelines now say that they're superior to warfarin. The first one approved was Pradaxa in 2010. Okay, so I love this slide to sort of make things simplistic. Why are they now preferred over warfarin? Well, the slide pretty much tells you. You can get the time to maximum onset within 2 to 4 hours, whereas Coumadin takes days. That's why we have to do a lot of bridge therapy with Coumadin when you have to overlap with a low molecular heparin or heparin until your iron is therapeutic. Look here. This means drug interactions, okay? All kinds of drug interactions with Coumadin. The food interactions, again, your vitamin K issues there with warfarin. You don't have to monitor, PT, INR. for a while, people would say, well, at least with Coumadin, I can reverse the drug. Well, we have now antidotes for our newer drugs. We have Praxbind for Pradaxa, and we have Andexa now, which is available for your TNA drugs. So we now have antidotes available. They're quite expensive, but we do have them available. Okay, so the first class to talk about is direct thrombin inhibitors. So what do these do? Yes.
What's the half-life of the antidote?
I'd have to look that up.
Okay, I'm sorry, I just was.
I don't have. I cannot
because,
recall that.
Yeah, because I was always curious because I just saw the slide. It came to my mind. But vitamin K, we give for Coumadin, when people are bleeding, and that sucker can stay in your bloodstream for a long time.
Yes, it can.
And so then it becomes an issue of how soon you can reverse it. So I just thought I was putting, I think it's not a bad idea to, because it's so new. And
It is.
And I have no clue.
And I'm not as familiar with it off the top of my head because I don't deal in an acute setting, so I need to look it up. But he's right. People would get vitamin K resistance on Coumadin. You come in, you get the iron already, they go into surgery, they slam them with 20 milligrams of vitamin K. And it makes it a nightmare with that patient in the Coumadin clinic because you're dealing with all that. It takes up to 10 to 14 days for that vitamin K to wash out. But I don't think you're dealing with quite the problem here with these antidotes.
Yes, what it,
Praxbind is approximately the half-life is 47 minutes, I'd say.
how much?
It's a,
47 minutes.
47 minutes?
it's a really super fast, continuous,
And how about
infusion.
Andexa? Yeah.
Andexa? So the rule of thumb is 5 half-lives to get out of your system.
Yep.
So let's make it 47 minutes, make that an hour. So within 5 hours, it should be out of your system. The reason it becomes important is, let's say somebody who needs to have, surgery or who's at a very high risk, you want the anticoagulation to kick back in. Let's say I have a not that we're going to use a mechanical valve or anything, but I'm just saying. So it's good to know exactly how soon we can get it back.
Yeah.
Is that Andexa there too? Or it's
Yeah, the clearance for index is approximately 4.3 liters per hour, but the elimination half-life ranges from 5 to 7 hours.
So 5 to 7 hours. So that becomes 25 hours for Andexa. Praxbind becomes 5. What I'm saying is 5 half-lives. So 5 half-lives is the amount it takes for 95% of the
Yeah,
drug to
basically
get-
98.5% to get out
about
of the
98% of the drug to get out of your system. So if you do the math that way, so Praxbind is a little bit more favorable, what it seems like. So not to digress, but I just thought it's all of a sudden it came to my mind.
That's a great point. I mean, it's a very good applicable point in the real world. Absolutely.
Thank you, Willie. Thank you.
Yeah. So basically, the direct thrombin inhibitors, these directly inhibit factor 2A. Okay, that's thrombin. Our older drug is Angiomax. The really old drug is argatroban. We hardly ever see that. And of course, we have Pradaxa. Okay, all can cause bleeding thrombocytopenia. Argatroban is given IV, as well as bivalirudin. The PO versions, obviously, Pradaxa. Okay, so some things here. This drug is called Angiomax. It's been around for close to 20 years now. It's an infusion. The key thing is we use it a lot in the cath lab. You could use it even in renal failure. So that's one thing that is an advantage of this drug, where I poll my students, when they come to me, like, what'd you see at this hospital? And some will say, yeah, on our renal cases, they still see Angiomax use. So that's a little niche for that drug. You've got a nice short half-life there. Mainly what you're going to see is used in the cath lab is just dumped PCI.
Hey Randall,
Yes.
that's kind of pretty interesting, because this is a DTI, and so is Pradaxa.
Mm-hmm.
And Pradaxa actually has renal implications,
It does.
whereas this doesn't.
Yeah, it's
I think maybe it has something, maybe have to do with the 30-minute half-life.
yeah.
It's a positive, because this is also excreted mainly in the urine.
It certainly is. I think you're right though on that point, and
The
that's
half-life is probably the reason why, we don't have that much renal implications, so.
Exactly. That's an excellent point, and that's why this drug really isn't used outside the cath lab because it's a short half-life. So pretty much if you look at guidelines, you can use this drug basically as an alternative to an infusible GP2B3 inhibitor. We have the IDP12 antagonist, Cangrelor. Some people go ahead and like with low with the oral agents like Brilinta, and it's not a platelet talk. That's basically where you see Angiomax used. This drug I'm not going to spend hardly any time on. It's an old as dirt drug, but argatroban. Mainly where you might see it used, again, if you have to have an anticoagulation in a patient with HIT syndrome during the heart cath. I think when they use medical leeches, I think it's Liparudin. That's it. I talk to my students about medical leeches, believe it or not, but it's a direct thrombin inhibitor. So obviously, Pradaxa, non-valvular AFib, 150 BID. You can use the drug for DVT prophylaxis and hip replacement. As Dr. Sarah Jude alluded to, you do have to dose this drug renally. That is a concern. Okay. Some notes here: you do have more GI upsets and bleeding versus warfarin, but less intracranial bleeding. So when this drug first came out, that's a key niche. Is you might have more GI bleeds, but intracranial is a far worse bleed to have. Okay, so to wrap it up here, your selective 10A drugs. Obviously, we heard about one tonight. Xarelto, selectively target 10A. Okay, we have 3 on the market: Xarelto, Eliquis, Savasa. The key thing here is the advantage of all these drugs is less intracranial bleeds than Coumadin. They're oral. Like I said, I think these drugs are much better than taking warfarin. So again, Vivaroxaban, we have a dose there, 20 milligrams a day for AFib. You can use it for DVT prophylaxis. Treated active DVT-PE, 15 milligrams Q12 times 21 days at 20 milligrams daily. Okay, you can use this drug with a reduced creatinine clearance. And the thing I got to mention too is, as alluded to earlier, this drug does have an expanded indication, as if the others don't. So we now have it indicated for reduction of cardiovascular events in patients with stable CAD or PAD. It's 2.5 BID with aspirin. Now, students asked me a while back, well, okay, you got this dose back here for Rivaroxaban, and then you've got this dose here. And I tell them, well, I think the main difference with the dose here is you treat a different type of clot. So I simplify things for students. I say arteries plaque and veins clot. So what I mean by that is that's why more antiplatelet drugs come into play on the arterial side. And when you're dealing with a patient here with CAD or PAD, you're dealing more with arterial blood clot. So that probably explains why you have a little bit difference in dose there for Xarelto for that indication. Okay, so this came out of the Compass trial. Okay, so you have a little more GI bleeding than warfarin, but obviously, again, you do have less intracranial bleeds. Another drug I'll mention is Apixaban. It's a BID drug. The other 2 10A drugs are QA drugs. This came out of the Aristotle study. So when you dose this drug, if you have somebody over the 80, you have 2 of these. You have 2 factors here, 2 or more. If you're over 80, less than 50 kilos, creatinine over 1.5, you got to use the 2.5 BID. To treat the treated DVT, 10 milligrams BID, and then for 7 days, and 5 milligrams twice a day. Some other things about this agent, okay. Obviously here, you can use it with renal disease. You do have less major bleeding versus Coumadin. Non-significant less incidence GI bleeding versus warfarin. And of course you have the Aristotle study with the superiority over warfarin. Another agent I want to mention is Edoxaban, okay, also called Savasa, okay. Once a day, okay, so we have 60 milligram to 30 milligram dose there. This drug is kind of weird because you can't really use it with a creatinine clearance above 95. And of course, that's really puzzling to me. But pretty much in a key study, it showed increased ischemic stroke risk versus Coumadin. So that's what kind of is different about Savasa is you got to really avoid the use with a high end, and you have to be careful with the low creatinine clearance. All right, so here's some things I'll mention again. Less major bleeding versus warfarin. More GI bleeding for the 60 milligram dose, but less with the 30 milligram dose. So you have 2 different doses there for that agent. So with that, I think I've covered my portion. Just trying to give you the facts and the basics. So I didn't really get into a lot of clinical trial data, but due to time constraints, I didn't want to be too far off on that tangent. So. Any other questions before I let Dr. Sarah Jude take the floor?
Good.
I appreciate it. Thank you.
Well, since I started eating, I'm just going to finish and then I'm going to start.